Professor Michela Tosetti. She's going to be talking to us about hunting for neural mechanisms and with their quantitative measurements in the brain using MR imaging. It is my pleasure to introduce her to us today. She is a physicist whose research career has been dedicated to advancing magnetic resonance for in vivo applications with special interest in understanding brain mechanisms in terms of the function, the structure, metabolism, and connectivity in order to be able to develop quantitative tools to measure and better understand the complex changes that happen in the brain across different types of development. She has personally contributed to setting up one of Italy's first 1.5 Tesla MR imaging centers, which she did in 1996, and later led the installation of the country's only 7 Tesla MR imaging system. These milestones of her reflect how early she has been at the forefront of the imaging innovations in MR. She is currently the director of the Medical Physics and MR Laboratory at the Ultra High Field Research Center, and she brings together people and coordinates the actions of different experts across different professional backgrounds. She has modeled what we always look for in terms of modern neuroradiology, bringing multiple disciplines together. And she's currently teaching at University of Pisa, which has been doing since 2011 and holds the Italian full professor qualification in applied physics. Our contributions continue to shape both advanced MR research and its clinical translation, especially in the development of neuroimaging biomarkers. She coordinates the Italian methodological researches in MR, as well as grants and collaborations both in Europe and across other continents. It is my pleasure and I have the honor of welcoming you, Prof, to this meeting.
Thank you, Adenika. Thank you very much. Can you hear me well? So I reduce
yes, we can.
the
we can
gallery.
Hear you.
Yes, I reduce the vista and somehow.
It's fine. So just before we start, if there are any questions or contributions or comments as the lecture goes on, please let us drop them in the chat box and they will be attended to at the end of the lecture. Thank you.
Thank you so much. So, okay, here we are. And thank you so much for this kind invitation and your introduction. And I'm here to ask to Adesola to change the title of my talk in your list of edition, because thinking about my experience in Lagos past July and looking also at the distribution, I remove the neural mechanism because I think that this first seminar could be more related to magnetic resonance in the brain, but hunting for quantitative measurement. So, as you say, I am the blot point, and we are so small with respect to you from Africa, and so, but we are pretty close, just to know that we are not so far as we can see. I come from Pisa, and probably some of you have visited us because Pisa, there is the Leaning Tower in Italy, and is also considered the cradle of magnetic resonance because, as our colleague says, in my hospital, that is a scientific institute for research and hospitalization and healthcare, recognized by the Ministry of Health. So we have a clinical research activity and teaching. It is 20 kilometers far from Pisa downtown, and there is installed the only 7 Tesla MR facility in Italy in the Imago 7 Research Center. So together with this, we play also with the high field, 3 Tesla Premier. As well, we had play with 0 Tesla and 1.5 Tesla. The 0 Tesla is really a 0 Tesla because it's a mock scanner to help us to scan collaborative children. So my lab is devoted to, as I say, to technical development with an important, I say, high to the translation in medicine neuroscience. And so we work together. This is my group, and there is meanwhile, a big collaboration with the neuroscientists, with the neurologists, as Professor Guerrini, with radiologists, as Cosottini and Giacomo. So it's a multidisciplinary team, okay? So here we are. Now, we start. So in Pisa, you know that Galileo Galilei was born here. And so there is a very nice quote. They measure what can be measured and make measurable what cannot be measured. And together with this, there is another favorite quote to me, that is the effect of a concept-driven revolution with respect to a tool-driven revolution. The last one can allow us to discover new things that have to be explained. So, and MR is a wonderful tool. We can scan, as you have seen in all your seminary, from prenatal to adult age, and we can do a lot of measurement of multi-parameter in one exam. And I am surprised of the number. I just make a web search, and I found that this is the number of the people that annually receive a scan. And if you think in Europe, every year we scan more than 65 million of people, of human. That is more than all the inhabitants of Italy. So it's a very huge amount. Normally, you see the images in your scanner as anatomical sequences, so you optimize, and we will discuss about that, the sequences to obtain T1 weighted, T2 weighted, diffusion weighted, and so on. But so it's a complex, there is many contrasts. So all of them are contrast, not really measurement. And this is the reason why we have the W view in the title of our sequences, because when we acquire images, and so for example here at T1 weighted sequences, we have area of hypointensity, for example in white matter, we have dark intensity in cyst, or we have, if we apply, for example, another pulse, like an inversion pulse, we can have a weighted contrast in flare that allows us to differentiate other things. But in any case, what we are seeing is a contrast between different relaxation time. It's not a measure, it's just a contrast between different structure. Because the signal in every pixel is a complex function of T1, T2, TR, TE, or T inversion, and all of them are enclosed in our voxel. So conventional MRI as a camera is taking a picture as your mobile phone, and it's useful. It's extremely incredible and reachable technique, as we have seen. But in general, the image is qualitative. So there is something that looks darker, looks smaller or bigger, is subjective, as hard to reproduce between scanner, and need extensive radiological training because you need to understand all the semiotic of the signal with respect to the pathology. If we consider the MR scanner as a scientific instrument, we have to think about quantitative MRI. In principle, this can allow us to see change invisible to the eye. But if we want the MR scanner is an instrument, we have to introduce the idea of measurement theory. And so the measurement could be accurate, closeness to the truth, reproducible, and precision and sensitivity can be evaluated. Why? Why we want to extract and calculate the quantitative parameter? First of all, because quantitative is not qualitative, and potentially we can increase the sensitivity to change associated with a disease. First of all, it's the most important for comparison to normal range, and in my personal opinion, one of the most important reasons are the most important reasons are that you can follow up the natural history of pathology, as follow up, for example, the effect of a treatment, and should be in principle scanner independent and allow multi-center study and research. And this is something that I design my talk thinking about increase your capability to make multi-center study and research. At the end of the story, if we succeed to extract a quantitative parameter, we can look for a biomarker. Biomarker is a characteristic by which a particular physiological or pathological process, disease, can be identified. And a biomarker should be objective, quantifiable, and related to a peculiar biological process. We have two different models. So we can apply this in pathology. So measure, not see anatomical, physiological, biochemical characteristic of the brain related to physiopathology. Or in neuroscience, for example, understanding complex mechanism, representation of neuronal circuit, study development and aging, and so on. But first of all, in MR, we have to evaluate the potential physiological meaning. So the specificity, that what kind of biological change has occurred. And so we need also information about physiological, clinical, psychophysical, biological measurement that can give us information about what we are measuring, and also the sensitivity, how small a biological change can be measured. Okay, so as I said, it's a very hard job, but we have demonstrated the feasibility and reproducibility. We have comparison and study and find a standardized protocol is necessary. This is in general true for every kind of imaging technique, but in particular for MR. We have established normal abnormal value, and so testing it in different clinical and physiological solutions. We have to test the sensitivity, specificity, positive and negative predictive values compared to a gold standard. So we need to understand which is the gold standard that we want to reach with MR. And so we pass through validation, reproducibility, test, retest, inter-site, inter-vendor. When we want to quantify a parameter, we need to consider in vivo also factors that can be considered before consider pathology. First of all, the age. We know that our brain change during development and aging. Looking, for example, at the thickness of the cortical during age. There is a difference in gender. It's well known that we have really a biggest corpus callosum with respect to male. And there is also different in tissue, obviously, because we want to differentiate in a quantitative way the cortices, for example, the gray matter from the white matter. And after relate to pathology. This is a complicated flow chart. I wanted to tell you that this key aspect are ready for any kind of MR technique. Also, if you want to optimize a sequence, you have always take into account which kind of hardware you are, coil, magnetic field strength, which kind of sequence you want to test, and so optimize all the sequence parameter, TR, TE, matrix, number of excitation, and so on. We have to decide the experimental setup, which kind of coil, and also which kind of organ or original interest we want to test. And after that, the data analysis and the processing algorithm, as well normative data and age of the acquisition, and factor related to pathology. I wanted to tell you that this is important for any kind of MR technique, either contrast or quantitative, because, for example, if you don't know that you have the hypointensity during the process of myelinization in children, you can recognize the pathology for no pathology. So it is important that this key point, a key aspect, are taken into account for all your implementation. When you make quantitative, is a little more block situation, because let's say sequence setup, data acquisition, and data analysis are key point, as well the age, the pathology that you want to study, and the magnetic field strength. We have some help, so we can test on phantom that help us to optimize or better understand which kind of process we are measurement, and you can find a lot of them. You can find for diffusion, for perfusion, for QSM, for spectroscopy. So there is a lot of phantom that can help you. And my advice is to try to play with this before to play with human to understand better how manage the scanner and how to do. We modeling the physiological response that could be measured with MR and brain. We're looking for R&D solution that could be new or could be also the one that you are available, for example, the best coil that you can use for that. We have to design the pulse sequence and obtain the best images we want. After that, we want to test in vitro and healthy for validation, and after that, modeling the MR signal. So together with the wonderful contrast that we have seen before, we can add also map that can identify a precise number. So a map is no, it's not an images. In a map, each voxel reports a quantitative value of a specific parameter. Value can be percentage value or dimensional measure with specific unit. Okay, so we need to understand, for example, relaxation time will be millisecond, or CBF will be millimetry, we will see after that. Okay, but we have an advantage. So we have the physics of the signal to quantify our parameter, because you know that there is a block, the Nobel Prize describe the relaxation of magnetization inside the voxel, and inside this voxel there is a different value of PD, T1, T2, but also diffusion. So if you know the physics of the process, you can change the block equation according with the process that you want to study. You can add, for example, gradient in diffusion, or if you want a flow, outflow, magnetization inside the voxel for perfusion. So we have physics at the base of this story. And we have a lot of things that we can do. So this is a very old slide that I have, and sometimes I add one of them, and I would like to highlight that there is other could be added on that, and that at the beginning, I am very old, so at the beginning of 90, some of them was artifact. So, for example, spectroscopy at the beginning of the story was the chemical shift effect related to fat and water, or diffusion arises from the fact that we now apply high gradient performance MR system. We discover that there is a loss of signal along the axon, and so on. QSM, the last one, is artifact related to this inhomogeneity of binode. So all of them at the beginning were artifact, and now are important Fourier of information. So to enter in detail, I just decided in this preparing this talk to mine is a methodological talk, just to give you some insight of these processes. And so I chosen these five topics. So the quantitative relaxometry that I use as a methodological workflow. So this is the patent of Damadian in 1974, when he applied for the first MR scanner. Okay, and if you look inside the patent, it says that the patent was apparatus and method for detecting cancer in tissue, and the patent in the abstract say by measuring the spin lattice relaxation time and spin relaxation time, comparing this relaxation time with their respective values, known normal and malignant tissue. So from the beginning, we want to measure T1 and T2. And you know that T1 and T2 is a very, very complex, long process if you want to apply it in the clinical practice, because we need to redesign the signal recovery and the signal relaxation, changing, for example, the TE for measure T2, and we have to sample a lot of images for just one measurement. So think about how long is your T1 measurement, how long is your T2 measure, and you have to replicate it so many times to acquire all the signal. There is also interesting clinical example. For example, in heart is easy because you have just two to tissue to measure. So it's not so complicated. It's very complicated. And to do that in brain, we need something like 40 to 2 hour from 2 hour to 3 hour per patient. You have seen that there is these opportunities, the magnetic resonance fingerprinting that you, I saw that a talk has been delivered on this topic. Is a very new technique in 2013 in which you have acquired a pseudo-random excitation sample of imaging. You make a comparison with the computed dictionary that contain all the block location. It can extract T1 and T1. I want to convince you that this could be a very interesting technique because look at on the left, there is the traditional sequence for one flip angle from one TE from one repetition time signal. But if you make a different flip angle, different repetition time, every voxel has its specific behavior. So if you look inside these images, the raw data on the left, this is a 2-year-old child. We say this is the sampling, the green line is the dictionary, and if you look at the image, you can see that we can pass throughout all the contrast, and you can also in the green circle depict the pathology. So it's absolutely a power technique and absolutely independent, is a physics, so it's independent. Acquire or extract from the dictionary different contrasts, so we have the reference are acquired exactly as a standard examination. You can also extract from MRF the gradient, the fast spin echo, and flare. So it's very interesting to implement also in your scanner because it seems very, very powerful things to connect the center together. So it's not go, okay. So as I say, this is a methodological story. When we develop these sequences for all the GE site, we start with a test. So we take a phantom with the T1 known substances, and we try to measure a resolution and accuracy. After that, we understand it can be the repeatability, so the test-retest study. And after that, we test the reproducibility. So different scanner has the same measurement. After that, you have implemented in vitro, we have to move in vivo with the same approach. So the accuracy, the repeatability with the same scanner but different subject. And after that, you take this traveling brain, move around and acquire the same test. At the end, the first paper we did with Cambridge, we acquired different 1.5 and 3 Tesla, the same vendor, and acquire really the T1 and the T2. That is pretty interesting. Obviously change with the magnetic field as expected because the T1 is reduced, increase, and T2 is reducing when you acquire with the different field strength. But at the end, the experiment it was good. So we implemented the same vendor this technique that give the contrast but also measurement. After that, I would like to do more. So with this project that is going now, I took 4 different sites with GE, Philips, and Siemens. So 2 GE with also a different hardware, MRPET. And we did the same. We acquired different function, we measured different T1, we tested intersite reproducibility and intrasite repeatability, and after that we move toward a traveling brain, and at the end we obtain a good map for all the vendor. So this is very important for multi-center study because T1 and in particular, but also T2 could be a really measurement of disease. And I wanted to give you an example. You have heard a lot, I see from the list of your summary, about the leukodystrophy and the pattern. So I work with neuroradiologists for 30 years, and all the time they discuss about white matter that can be less white or more dark. But definitely you speak about pattern, so alteration from the visual aspect of the pathology that is very important, but is not a really measurement. How we can transform the result that we can obtain in the ex vivo brain in the brain, because it's important also, for example, in this specific pathology that is, so a rare disease, mostly genetic based. The natural history of the disease, but more also now that we have a gene treatment and therapy, also to follow up after treatment this rare disease. And we have myelin. So this is a myelin related, and we have an axon. And we know that the modeling of an axon has different T1 and T2 if you are in the axon or in the intra or extracellular space. So in principle, we can model in the signal not only for T1 and T2 relaxation, but something like a different pool. And we obtain in a voxel, the answer is different if you have in one of these component of myelin or in water or CSF or white matter. So we modeling the signal for an axon. And what we obtain as the T1 and T2, as you say, but also the physiological properties that is the myelin content. And first of all, we test on pathology. We are able to detect the alteration. Yes, we are, because you have here a flare with an alteration, but here you have a number. And moreover, this technique can depict, for example, the normal neurodevelopmental say behavior that are expected for myelin water fraction, because we know very well that myelinization changes along the neurodevelopment. And what we did, we acquired a lot of data from 2 years to adult range, and we succeeded to recover the curve of neurodevelopment as expected. But moreover, if you apply this to a group of leukodystrophy, you can depict the alteration in green that are physiopathology of the disease. So it is really, because it is a measure of myelinization and is also a good measure of pathology. And so we are doing the same now, submitted at SMRM, to transform the T1 map that we acquired in the previous study and transform this in myelin water fraction. And it's an important matter of fact, because myelin water fraction is independent from the field. So T1 and T2 change along when increase the field strength or reduce the field strength, but myelin water fraction is an absolute measurement. So this is the way in which we proceeded. And this is an example in which you have to test, you have to travel, and you have to understand what you are looking for. The fMRI is another thing that you can easily implement in your scanner, because it's very easy to have an API installed. But what I wanted to highlight to you today in this example is what we are measuring. Could it be quantitative or not? This is an important factor of fact. So when you study cortical activation, you have, after neural activity, a lot of metabolic rate as well as the physiological phenomena. And all learn something like increase of CBF and CBV, the change in the hemoglobin compound, change to a blood key effect that change the T2 star of our images. But if you look at the metabolic and physiological flow chart, there is no a proportional influence between the two signals. So it's not really a measure, because it's not really connected. And if you look at the perturbation that is induced, is an effect of many signals. At the end, we obtain a difference between, again, the relaxation curve that we obtain from a voxel. We have to remove all the other signals that arise from our brain. And this is the reason why, because we acquire different conditions. And at the end, the measurement that we did is not a really measure, but it's a statistic map. So it's a statistic map of difference between different conditions. In this case, it is, if you wanted to say that is, we put a parameter in a map. When you do fMRI, you put voxel on a parameter map that is a identify the brain activity, but is related to a feature of its time course or a combination of variable. And so somehow is not an absolute measurement, it's a relative measurement. As you can see, if I change the threshold of this signal, I change also the activation. But it's wonderful. I love this because it's my first paper on fMRI in 2000, but so you can see a lot of things on that, identify very, very precise lesion. And this is something that, in my personal opinion, you can implement in your scanner because it's very easy. It's good also at 1.5 Tesla and below. We can study sensory motor organization. We can study language in lesioned or also, for example, dyslexic patient. We are studying mirror neuron for example, to study intervention in cerebral palsy. My favorite is visual, in which we have studied a lot of, we did a lot of study also in newborn, as you can see in this picture. And also we use this as 7 Tesla, in which you can differentiate the single finger, just to show you that you can, at 7 Tesla, you can differentiate the sensory from motor task, and also the single digit from another. But at the end of the story is a perturbation. And this is an example of comparison between three different field strengths. And you see, you have in any case an hemodynamic response, and also the capability to differentiate between tactile and motor task. And this is the behavior of our signal that I say is a hemodynamic response function. That is the convolution of a lot of other effects. I wanted to highlight you the cerebral blood flow that indeed is more related linearly as CBF with the input function. So we have a spike here, and we have this perturbation around our brain, but again, there is some of this signal that is linearly connected. As happened if you look at the inflow effect of the neural activation. That is a T1, we can do a T1 measurement and measure the signal intensity. So if you look at the fMRI with arterial speed labeling, you can see that, for example, you can quantify a checkboard contrast that you know is changed. The neurons are more active when you have more contrast. And so it is really connected, and I'm proud to show, and as God we know, this Iris Asilani acquired in Lagos in 2025 a motor task with this task, perfusion. Why I wanted to tell you about perfusion? Because to me, it's something that you need to implement in your scanner, because for the high scalability that can have, and also the clinical applicability. Okay, you know very well that we are measuring something that is really at the capillary territory. So with GBF, we would like to measure what happened at the level of at capillary level. And the only way to measure this are using radioactive isotope and ionizing radiation. I don't enter in detail because you know very well this technique. I just wanted to highlight you that again, we model in the block equation adding what is related to this physical effect, so the inflow and the outflow inside the voxel. But I use this to tell you about the gold standard. When you implemented a quantitative measurement, first of all, you need to know what we are looking for. Obviously, PET is position tomography is the gold standard of this kind of measurement. So when we implemented so far this technique, we look at the literature, and we found very few work on the during development with the perfusion measurement. So there is, in particular, Kennedy and Sokolov in 1957, using a very, very invasive method, measured that the average global cerebral blood flow was 1.8 times higher in children than in adults. This is the only publication about cerebral blood flow in children. And the other one was Chugani in 1987 that measured with PET in 29 children the uptake of glucose. So when we at the time developed this sequence, we compare our result normalized to adult value, and the CBF alternance pillability exploring PISA has really a good agreement with the PET1. But was incredible, we found exactly that the average, the cellular blood flow in children was 1.8 higher than in adults. So it seems that is a really measure on that. Just a few examples to say that it's very important, in my personal opinion, that we implement this. This is a case of schizencephaly. It's a disorder of neural migration, and the etiology remains unclear and seems that is often located in vascular territory. So something related to that etiology could be implemented. So the lesion, you can see the lesion is very important, severe, but it's very good located. But if you look at perfusion, all the artery has been hypoperfused, and the only region in which there is the CBF is ready is the region where the motor task response. So in the perfusion deficit in cardiovascular disease like stroke is important. The important implementation on your scanner is a quantitative. We need no contrast agent. This is a very interesting work from Africa, from Egyptian Journal of Radiology, in which they added these sequences either for acute infarction with and without penumbra. And so it is very important. Because I say this, because we have a burden on cardiovascular disease, and your country seems to be one of the more involved in this process. So the idea to put in your scanner something that can really be useful in the increase of these important things, and alternate speed labeling could be really implemented also in a multi-vendor with pretty near identical sequences in a multi-center study. So there is this paper, but also there is also one of the first consensus paper on ISMRM on arterial spillability, and now we can add also the new recommendation that arise from a collaboration in the clinical application. I want to tell you that this is a look at dementia. Why I wanted to talk about this technique applied to dementia? Because if you look at dementia rate, again, your country it seems not so related to other this kind of case. But if you look at the life expectation in 1850 and 2000, we see that life expectation changed dramatically, and in particular, your life expectation is increasing. So in Italy, we have, as in Japan, we have the longer, we have the huge amount of dementia people, but we have also the high life expectancy. So it's something that you will face soon, and have also a technique that can allow you to study this kind of pathology, in my personal opinion, is a very important thing, also because you are in time. We were not, but you are, because lifestyle modulate the brain. So we know that if you have a spring rain, so we do a good lifestyle, you can increase your cognitive reserve and vascular reserve. If you don't, if you have acid rain, we have face the neurodegeneration. But there is this idea of Kosten and Gardner approach, in which you continue to drain bladder, cognitive reserve, and vascular reserve. So they reach. So what we study is a very, very old elderly population to try to understand is Alzheimer's disease is a vascular disorder or a neurodegenerative disorder with vascular consequences. What is certain is a cellular perfusion, energy, neural function, brain metabolism, and tissue injury are all connected. So we would like to know if hypoperfusion is connected to cognitive dysfunction. So this is a project that is related to neuroprotection, neurodegeneration. I wanted to show you that if you compare subject cognitive impairments, so not really dementia with the mild cognitive impairment, that is the promodal state of dementia and Alzheimer's disease, you find a huge amount of difference in this elderly population in perfusion map. And this is another technique I think you want to implement and easy to do. This is the voxel-based morphometry. So we divided our brain, and now I show you in subcortical cortical structure. You see there is more than 100 patients on the left, and so we are looking inside the brain, and we found that there is a different value in different of this subgroup of patients, and all of them have a grade of different dementia. And most importantly, and this is what I say, that if we apply a training of cognitive exercise and all the painting, all the things that can give us a good environment and a good life of style, this mild cognitive impairment recover the hypoperfusion that they have in hippocampal region. So, as I said, 7 months of training has been sufficient to recover a damage in perfusion brain. Obviously, you can do this also in the atrophy aspect, and so we move fast toward another thing that I would like that my advice is to implement is all the technique on based on voxel-based morphometry that allow to put together multi-subject, multi-center, and so on. So it's easy, you segment the tissue, it's a complex, but now there is a lot of a program that can allow you to automate this process. At the end, you have different region in which you can calculate the cortical thickness and the volume. For example, these are 3 different map obtained in this network of neuroscience, Italian network, with different vendors. Again, they are absolutely reproducible between the 3 sites. So if you make a good sequences with all the parameter setup, you can make a really good measurement. And after the final step, it comparison with the healthy and pathological brain. Just a very, very brief. This is a very old study I did on 38 subjects with autism spectrum disorder compared to, again, to age-matched AUQ control. At the end of the story, we depict that in the autism children, there is a region that is have a different gray matter probability. So they have a region really alterated in autism female children. And what is incredible is that in that day, at a certain point, an 8-year-old male with autism spectrum disorder high function arrived to our 1.5 Tesla, and he had the same. It was not autism because there is a tumor inside the brain, and it had the same tumor in exactly the same region we this detected in a multi-subject. So this is the reason why, on certain point, I decided to apply for a 7 Tesla. I just wanted to go. I hope to have 10 minutes to recover my absence for the power that we acquired with 7 Tesla. The reason is because the signal to noise ratio increase. But I want to just to highlight you that during the first Aberdeen machine that I showed before for 1979 in Aberdeen, in the same period in 1982, Tom Budinger, Paul Lauterbur, the Nobel Prize for MR, built a 7 Tesla because from the beginning, the physics say that increasing the field increase also the signal to noise ratio. And now we have also in Europe a 14 Tesla in the Netherlands that will be built soon. So the reason obviously is the quality of the image, but I wanted to tell you about that for 2 reasons. First of all, that with a higher field we can do what you say T2 star weighted. I say that there is star performance. T1 is the best acquisition I can do a low field. At 3 Tesla, the T2 flare is the star, and there is a T2 weighted for the other. There is a new technique, the quantitative technique, that is the susceptibility map. Due to the fact that we have different diamagnetic and paramagnetic things in our brain, we can differentiate between lipid, myelin, calcium, osteohemoglobin, iron, hemosiderine, and so on. In our protocol, we had also these sequences in which you can see gellification, calcification, myelin content, iron deposition, microvascular, and for example, we depict on T2 star the signal loss of Parkinson disease, but when we discover the things that was 2014, immediately I go to the 3 Tesla and my 1.5 Tesla try to implement it because it is possible even if it's not possible to acquire. And also at 3 Tesla, but also 1 Tesla, it's possible to use and depict things. I started to go faster ahead. As I said, it is possible to implement it, and also in this work we have also demonstrated that is pretty reproducible between scanner, even if a different subject and there is no normalization, but we can also standardize around your country this kind of measurement. And it's very important to look at this. This is a cryptogenetic epilepsy and was a negative low field, and with the high field we detected differences, but with QSM we found the lesion. So remember, the implementation on the scanner of the technique can help you a lot. So I wanted to finish to say that at 7 Tesla there is more artifact. I just not talk about 7 Tesla, even I know that Godwin would like, but just to say that we are on the same boat. If you look at the different field that we can have, so from low field to ultra low field, ultra high field, the physics is the same. There is no difference between the physics behind these things. And more things, if you look at the slides on the first machine and also the seventh, I think that this is not history. This is present and future, because we have 11 Tesla, and we have also the 0.047 Tesla of Andrew Webb in Leiden. So it's not the past, it's the future. And moreover, if you look at the novel strategy at ultra low field and ultra high field, you depict are very, very pretty close. So we have to mitigate the inhomogeneity of the B1 and also on B note, and we have strategy to try to reduce with some detector all of both of them. As well, at low field you have the necessity to the cancellation of the interference with outside. If you look at the DL, the deep learning technique for imaging, you can find that at 55 milli Tesla, you can use this to improve the signal to noise ratio and obtain super resolution images. As well, we use, for example, to correct and obtain higher and higher resolution amplitude range acquisition. Or, for example, there is the DL for system design, and this paper show how the application moved from 0.5 Tesla to 7 Tesla. At the end, the sequences that can allow us to resolve problem, for the low signal to noise ratio, this is a magnetic resonance fingerprinting, 50 millitesla. And this is what we develop 7 Tesla to reduce, to measure T1, T2, and also to reduce the B1 inhomogeneity. So the physics is the same, the strategy are common, so we are only one community. So I hope that I just give you some insight on the 1,000 kilometers that we have on our brain, and how fascinating hard to implement a quantitative measure if you follow a precise flow chart of implementation. I wanted to tell you that there is this toward quantitative MR for the clinic is not a review for only physicists, even if it's a Physica Medica, because it's written to all of you that want to develop sequencing in a multi-center, subject fashion, if you want. I'm very proud that there is a few paper also on my group, and in particular not on my group, but what is my advice that I think that you are doing to do now is to create a network. This is all the many of the paper and many of the images that you have seen arise from the collaboration of 22 research hospital, in which we built an imaging platform of the Italian neuroscience network. So putting together competencies and method in all the sites, we can increase our critical mass, and as a small country we are became a country that can be competitive with the big story. So I love the bridge. So I hope that this talk can build a bridge between Italy and you, wherever you are. And remember that tell me and I forget, teach me, and probably I hope you remember what I say, but if we involve together in research, everyone learned. And thank you so much for your attention.
Thank you so much, Prof, for that insightful and engaging presentation. We really appreciate how much you brought clarity to this very complex part of neuroradiology. I'm sure that our audience has gained a lot of different and valuable perspective from the lecture.
So I'm at disposal for any question, and sorry if the power disappeared from my hospital. I hope that the scanner are still alive during this shutdown.
So we will take questions for Prof now. If you have any questions, please just use the virtual hand raising icon, or you can leave them in the chat box and I will direct them to her.
So I can hear well. So any question?
I think Professor Gole has a question. Prof, please, you have the floor.
Yeah, thank you very much. Michela, thank you so much for that beautiful lecture. It's very, you covered the basis from the bottom to the top. It's so excellent. Talking about neurodegeneration. Look, it's so mine is just a comment. And quickly to say that it's very strange to find out that electricity will go off in Italy. This is very strange.
It seems like we in Lagos. It's strange.
It's like it's in Lagos.
Never happened. It's just crazy. So I'm also in everything because there is the scanner ongoing. So I don't know what happened. And never happened. Just today, because in principle I am together with you in Lagos now. It's really in this way.
Yeah, it's really this way. Yeah, very strange.
Absolutely, yes, absolutely strange. Never
Anyway,
happened.
it never happened.
Yeah.
Anyway, we hope your scanners are still safe. Anyway, thank you so much for.
As we finish, I ran to see what happened.
All right, thank you very much. Anyway, that's just to say thank you, beautiful lecture. Thank you so much.
Thank you, Godwin. Thank you so much.
Yeah.
And again, if you any question you are now, we spend more time with respect to the schedule due to my shutdown period. So if you want to write me, you can Google me. You find everything about email and phone and everything. Godwin know very well. I am completely disposal for advice and my group if you want to implement. But what I wanted to finish to say that I have chosen things that you can easily implement it in your scanner. And first of all, when you start to play with the neuroradiological world, start to think also to implement some quantitative measurement, because tomorrow we can need this, as I said, to put the data together for neurodevelopment, rare disease, neurodegeneration, and so on. So my advice is to start immediately when your scanner